Hello, good evening, everyone. My name is Darwin Chimba. I'm a final year medical student from Copperbelt University School of Medicine in Zambia, and I'm the president of the Association of East African Neurosurgeons. It is a wonderful day to have yet another meeting, another presentation, going to be done by Lisa from Cameroon. She's going to introduce herself later on. But before we get into the presentation, we're going to have everyone on the panel to introduce themselves. Crescentia, please, you can introduce yourself.
Hi everyone, my name is Crescentia from Tanzania, currently studying medicine in Russia, final year. It's a pleasure to be here.
Thank you so much, Crescentia. It's a pleasure to have you here. All right, Namfa, Joe, you can introduce yourself.
Well, hi everyone, I'm Namfa Joao, third year medical student from Cameroon at Université de Montagne.
Thank you so much, Joel. Happy to have you here. Ben.
Good evening, everyone. My name is Ben Ojakapeli. I'm a fifth year medical student from Moi University in Kenya. Thank you.
Thank you so much, Ben. Happy to have you. Adele, I hope I pronounced the name correctly. Okay, Tabo.
Hello, everyone. My name is Tabo Mwatsi. I'm a first year medical student in the University of Lusaka here in Zambia.
Thank you so much, Tabo. Dr. Anthony.
Hello, everyone. Thank you, Darwin. My name is Anthony Kubuin, a medical doctor, Lagos, Nigeria, research fellow AFAN, General Secretary AFAN. Glad to be here.
Thank you so much, Dr. Anthony. It's a great pleasure to have you. Emmanuel Mukambo.
Hello, everyone. My name is Emmanuel Mukambo, a fifth year student at the Copperbelt University, Zambia. I'm pleased to be here.
Thank you, Emmanuel. It's a pleasure to have you. Okay, so we are going to go straight into the presentation by Lisa. Please, Lisa, you can share the screen, introduce yourself, and begin the presentation. Wishing you the best.
Thank you. Hello, everyone. I hope everyone can get me.
Yes, we can.
I'm called Tachang Lea, I'm a third year medical student, University of Montagne in Cameroon, and I'm going to be presenting on the cerebellum and the brainstem in the AFAN clinical neuroanatomy series. I think we can get started now. First, we have our plan, which involves the introduction. We'll talk about the generalities, descriptive anatomy, clinical application, conclusion, and then we can have our references. With the introduction, first, we're going to talk about the objectives here. Basically, we're going to first know how to identify different parts of the brain, know the embryology, anatomy, and functioning of the cerebellum and the brainstem, know the clinical features of pathologies affecting the cerebellum and brainstem, know the application of the anatomy of the cerebellum and the brainstem. Okay. Now, talking about the embryology of the brainstem, of the brain, we can see here we have the lateral view of the neural tube. In a 3 to 4 week embryo, it segregates into the procephalon, the mesocephalon, and the rhomboencephalon. The procephalon will give rise in a 5th week embryo. The telencephalon and diencephalon, the mesocephalon is going to remain the same, not change. And the rhomboencephalon is going to give rise to the metencephalon and the mesencephalon. And then we can see that as the embryo grows older, it's going to, the telencephalon is going to differentiate into the cerebrum. The diencephalon, we're going to have the eye cup, the thalamus, the hypothalamus, and the epithalamus. The mesencephalon will give rise to the midbrain, metencephalon, the pons, and the cerebellum. Mesencephalon will give rise to the medulla oblongata. Next, we have the parts of the brain. You can see from this slide, we have the lateral view, the sagittal view, superior view, and inferior view. In the lateral view, you can see the frontal lobe, you can see the temporal lobe, you can see the cerebellum and the brainstem, which we're going to be talking about or emphasizing on. Superior view, you can see the 2 hemispheres of the brain. you can see the parietal lobe, you can see the occipital lobe as well. Inferior view, you can see from inferiorly the cerebellum and the cerebellum. You can also see the occipital lobe, the sagittal view as well. Like this, that's the difference in the viewpoints. Now let's get into the main topic of today, the cerebellum and the brainstem. The cerebellum is situated in the posterior cranial fossa and is covered superiorly by the tentorium cerebelli. It is the largest part of the hindbrain and lies posterior to the fourth ventricle, the pons, and the medulla. The cerebellum is somewhat ovoid in shape, as you can see, and constricted in its medial part. It consists of two cerebellar hemispheres joined by a narrow median vermis. You can see the vermis right here. It is estimated that if the human cerebellar cortex were completely unfolded, it will give rise to a layer of neural tissue about 1 meter long and averaging 5 centimeters wide, a total surface area of about 500 square centimeters, packed within a volume of dimension of 6 by 5 by 10 centimeters. The anterior lobe, which you can see right here, may be seen on the superior surface of the cerebellum and is separated from the middle lobe by a wide V-shaped fissure called the primary fissure, which you can see right here on the diagram. The middle lobe, sometimes called the posterior lobe, as we see, which it is the largest part of the cerebellum and is situated between the primary and the uvulonodular fissure. And then now the flocconodular lobe is posterior to the uvulonodular fissure. I don't think the diagram doesn't show the flocconodular lobe, but then they've told us about, we know about the location, which is still posterior to the uvulonodular fissure. Now we continue the different parts of the cerebellum. Here we can say the cerebellum can be divided into two cerebellar hemispheres, and also the hemisphere, they can be divided into 3 parts. We have the cerebellum, the spinocerebellum, and the vestibulocerebellum. Now the cerebellum, which we see here, is this part right here, receives input from the cerebral cortex and is involved with planning and initiating movements. The spinocerebellum, which consists of the vermis and the medial part of the cerebellar hemisphere, it receives information about limb position and touch and pressure sensations from the spinal cord. It then uses information, for example, to compare where a limb is in space with where it should be if the movement were going as planned. If there's a discrepancy, the spinocerebellum can modify motor signals to correct any errors in the movement. Then now we have the vestibulocerebellum, which is important in maintaining equilibrium, balance, and posture. We're going to move on to the structures of the cerebellum. The cerebellum is composed of an outer gray matter called the cortex. We can see it right here, cerebellar cortex, and an inner white matter, which we see right here. Embedded in the white matter of each hemisphere are 3 masses of gray matter forming the intracerebellar nuclei. The cerebellar cortex can be regarded as a large sheet with folds lying in the coronal or transverse plane. Each fold or volume contains a core of white matter covered superficially by gray matter. A section made through the cerebellum, parallel with the median plane, divides the folia at right angles and the cut surface has a branch appearance called the arbor vitae, which we see here. Still on the structure of the cerebellum, the gray matter of the cortex throughout its extent has a uniform structure. It may be divided into 3 layers. We have an external layer called the molecular layer right here, a middle layer which is called the Purkinje cell layer here, and an internal layer which is the granular layer. Talking about the inner matter, we have 4 masses of gray matter, like I mentioned, which are embedded in the white matter of the cerebellum on each side of the midline. From lateral to medial, these nuclei are the dentate, we see it here, the dentate nucleus, the amboliform nucleus, the globus nucleus, and the fastigial nucleus. We're going to move on now to the communication pathway of the cerebellum. The cerebellum communicates with the rest of the nervous system through three large pathways called the cerebellar peduncles, as we see, which include the superior, the middle, and the inferior peduncles. The cerebellum attaches to the brainstem by three groups of nerve fibers called the superior, middle, and inferior cerebellar peduncles, through which efferent and afferent fibers pass to connect with the rest of the nervous system. When information is sent to the cerebellum, it takes an indirect path to reach extensively branched cells called the Purkinje cells. These cells then project to a group of nuclei in the center of the cerebellum called the deep cerebellar nuclei. The deep cerebellar nuclei then sends information to the various areas in the brainstem and the thalamus, and that can influence motor areas of the cortex or descending motor tracts to modify movements. Talking about the arterial supply of the cerebellum receives vascular supply from three main arteries that originate from the vertebro-basilar anterior system. The superior basilar artery, abbreviated SICA, the superior cerebellar artery, abbreviated SICA, the anterior inferior cerebellar artery, from which arises from the basilar artery, as we mentioned, and the posterior inferior cerebellar artery. Talking about the venous drainage of the cerebellum. The cerebellar veins are the veins which drain the cerebellum. It is drained by the superior and inferior cerebellar veins and their tributaries. From the upper surface of the cerebellum, blood is drained straight into the straight transverse and superior petrosal venous sinuses. Clinical application of the neuroanatomy of the cerebellum. We have lesions of different parts of the cerebellum. Like we have, like, for example, cerebellar dysfunction, lesion of vermis, which involves truncal ataxia, nystagmus, because of connections of vermis with labyrinth. The vermis is also related to emotions. Anterior lobe lesions, which get, as you can see, gait ataxia, staggering, which is a staggering gait, that's just what it means. We have the neocerebellar lesions as in coordination of voluntary movements of upper limbs, which results in intentional tremors, action tremors, overshoot movement, and speech is also defective, both phonation and articulation. So we're still on the clinical application of neuroanatomy of the cerebellum. We also have the cerebellar cognitive affective syndrome, abbreviated CCAS, also known as Sherman's arteries, Sherman's arteries supplying the cerebellum. Patients present with inattention, that's inability to be attentive, grammatical errors in speech, patchy memory loss, blunting of emotional response. The features we have muscular hypotonia, intentional tremors, tested by finger to nose test or heel to knee test. We also have adiadochokinesis, which is the inability to perform rapid and regular alternating movements. Application of the anatomy of the cerebellum in surgical practice. The anatomy of the cerebellar tongue side and surrounding fissures, arteries, and veins are reviewed using cadaveric brain specimens. The surgical approach uses the three-quarter prone position, a sub-occipital craniotomy, and wide splitting of the tonsillo-biventral feature. The supratonsillar approach differs from the transvermial and tolovelar approaches to the fourth ventricle with a more superolateral trajectory that leads instead to the inferior cerebellar peduncle. By splitting the tonsillo-biventral fissure and mobilizing the tonsil inferiormedially, the point of access to the lesion is deepened and transgression of normal cerebellar tissue is minimized. This elegant approach is ideally suited to the removal of cavernous malformations. We're going to move on to the brainstem. The brainstem is a distal part of the brain that is made up of the midbrain, the pons, and the medulla. Each of the three components has its own unique structure and function. Together, they help to regulate breathing, heart rate, blood pressure, and several other important functions. The brainstem has three broad functions. Number one, it serves as a conduit for the ascending tracts and descending tracts connecting the spinal cord to the different parts of the higher centers of in the forebrain. We have number 2, it contains important reflex centers associated with the control of respiration and the cardiovascular system and with the control of consciousness. It contains important nuclei of cranial nerve theory through 12. One of the 3 divisions of the brainstem, the midbrain, which is one of the 3 divisions of the brainstem, at the level of the midbrain, the third ventricle has narrowed to form the cerebral aqueduct, which connects the third and the fourth ventricle. We have the third and the fourth ventricle of the cerebral aqueduct. The tectum primarily consists of the superior and inferior colliculi, as you can see, which are clusters of neurons that together form 4 bumps on the posterior surface of the brainstem. The superior colliculi are thought to be involved in correcting behavioral responses towards stimuli in the environment, while the inferior colliculi are known for their role in auditory processing. We have the cross-section of the midbrain, and we can see that the area in front of the cerebral aqueduct is called the tegmentum. We have that right here. The anterolateral portion is made up of 2 structures called the basis pedunculi, which we have here. Talking about the tegmentum, it contains a variety of ascending and descending tracts, like the medial lemniscus and anterolateral tracts. It also contains fibers from the superior cerebellar peduncles, the main output pathway of the cerebellum, and a red nucleus. A nucleus thought to play a role in motor coordination. The tegmentum contains nuclei for cranial nerve 3 and 4, as well as neurons that are part of the raphe nuclei, the raphe nuclei, which is the major serotonin producing neuron in the brain. And then we have the ventral tegmental area, which is one of the largest collections of dopamine producing neurons in the brain. The basis peduncula include the crura cerebri, which are 2 large bundles of axons that contain fibers from motor pathways like the corticospinal and the corticobulbar tracts. The basis pedunculi also includes the substantia nigra, which is another major dopamine producing structure in the brain. Finally, the area surrounding the cerebral aqueduct is called the periaqueductal gray. Periaqueductal gray is known for its role in pain inhibition. Now, the clinical application of neuroanatomy of the brainstem, we have the cross syndrome. Talking about brainstem syndromes, I'm going to mention them briefly because there are a lot of potential brainstem syndromes. But first, we can mention a cross syndrome, which can be a pretty distinctive lesion for a brainstem lesion, and this involves 2 parts. We have the first is a dysfunction of a cranial nerve on the same side. Second, dysfunction of the lung tracts to the other side. Now, we can take into consideration the different clinical relevance of the different parts of the brainstem. Midbrain lesions. Talking about Benedict syndrome or paramedian midbrain syndrome, is a rare type of posterior circulation stroke of the brain with a range of neurological symptoms affecting the midbrain, cerebellum, and other related structures. Benedict syndrome, it involves 3 particular structures in the midbrain, which is the apical Westphal nucleus, which carries parasympathetic fibers of cranial nerve 3. We have the nucleus of cranial nerve 3, which is the oculomotor nerve, and a red nucleus. It is characterized by the presence of an oculomotor nerve palsy and cerebellar ataxia, including the tremor and involuntary chorioatotectic movement. Neuroanatomical structures affected include the oculomotor nucleus, the red nucleus, the corticospinal tract, and superior cerebellar peduncle decussation. It has a similar cause. It has a similar cause, morphology, sign, and symptom to Weber's syndrome. The main difference between the 2 being that Weber's is more associated with hemiplegia, that is paralysis, and Benedict's is more associated with hemiataxia, which is disturbed coordination of movements. It's also similar to Claude syndrome, but it is distinguishable in that Benedict syndrome has more predominant tremor and chorioatotectic movement, while Claude is more marked by the ataxia. Oculomotor nerve palsy, which is basically the eyeball gazing downward and in a downward and upward position. We have diplopia, we have miosis, we have mydriasis, and loss of accommodation reflex. Contralateral loss of proprioception and vibration sensation. Also, we have the contralateral loss of proprioception and vibration sensations. Cerebellar ataxia is basically involuntary movement. Here we have a deep brain stimulation, which may provide relief from some symptoms of Benedict syndrome, particularly the tremors associated with the disorder. The next clinical application of neuroanatomy of the midbrain, we have Weber syndrome. It's classically described as a midbrain stroke syndrome and superior alternating hemiplegia, which involves oculomotor fascicles in the interpeduncular systems and cerebral peduncles, thereby causing ipsilateral third nerve palsy with contralateral hemiparesis. It is mainly caused by a midbrain infarction as a result of occlusion of a branch of the posterior cerebral artery, most commonly, or the paramedian branches of the basilar bifurcation perforating arteries. Clinical finding mainly involves the eyeball is down and out, ipsilateral squint. We also have ptosis present as the levator palpebrae superioris nerve supply is disrupted. The pupil is dilated and fixed. We have contralateral hemiplegia, the CT scan and MRI. And the MRI might help in delineating the cause or the vessel or region of brain which was involved in the stroke. Next part of the brainstem, we have the PONS. The PONS is a portion of the brainstem lying above the medulla oblongata and below the cerebellum and the cavity and below the cerebellum and the cavity of the foot ventricle. The PONS is a broad horseshoe-shaped mass of transverse nerve fibers that connect the medulla with the cerebellum. The PONS is Latin for bridge, and it was so named because the anterior part of the PONS, which is known as the basal or basilar pons, causes the pons to look like a bridge that connects two hemispheres of the cerebellum. The region behind the basal pons is called the pontine tegmentum or dorsal pons. The pons contains many tracts and nuclei, but in this presentation, I'll highlight just some of the more notable of these. Next, we'll talk about the communication pathways between the pons and the cerebellum. The basal pons doesn't form a direct connection between the cerebellar hemispheres, but the pons is attached to the cerebellum by the middle cerebellar peduncles, a major pathway between the brainstem and the cerebellum. The inferior cerebellar peduncles also travel through the pons to carry information to the cerebellum and to the superior cerebellar peduncles, which enter the brainstem at the level of the pons and carry information from the cerebellum to the brainstem. On this diagram, we see the cross section of the pons that's moving from the brainstem from left to right below. The pons form most of the floor of the foot ventricle and is home to several cranial nerve nuclei, including the trigeminal nuclei, which are involved in sensory and motor functions of the head and face. The abducens nucleus, which controls lateral movements of the eye. The facial motor nucleus, as we can see, which controls muscles of facial expression, and the vestibular nuclei, which processes vestibular information. The pons also contain the nucleus coeruleus, the largest collection of norepinephrine containing neurons in the brain, and some of the referring nuclei, which are the major serotonin producing neurons in the brain. We see the cross section of the pons, and we have to know that the pons also serve as conduits for many tracts passing up and down through the brainstem, like the corticospinal tract for voluntary movement, medial lemniscus for tactile and proprioceptive sensation, and spinothalamic tract for pain and temperature sensations. Now the clinical applying it in the clinical sense, we have first Miller-Gobler syndrome, also known as facial abducens hemiplegia syndrome or the ventral-pontine syndrome, and is one of the most classical cross brainstem syndromes characterized by unilateral lesion of the basilar portion of the caudal pons involving fascicles of the abducens and the facial cranial nerves and the pyramidal tract fibers. The diagnosis of Miller-Gobler syndrome is confirmed by clinical examination of cranial nerves 6 and 8, along with hemiplasia of upper and lower extremities. This activity describes the etiology, presentation, and diagnosis of Miller-Gobler syndrome and highlights the role of the interprofessional team in the management of affected patients. Because various etiologies might cause Miller-Gobler syndrome, we take a detailed history to exclude other causes like infection or vascular insult as parents of other neurologic deficits. Treatment mainly depends on the etiology of the disease. In some cases, the patients presenting with the multiple deficits require early consecutive measures together with multidisciplinary rehabilitation. We're going to move on to Fowler's syndrome. The inferior medial is also known as the inferior medial pontine syndrome and is one of the brainstem stroke syndromes occurring when there is infarction of the medial inferior aspect of the pons due to occlusion of the paramedian branches of the basilar artery. The presentation can be variable but manifests usually as a gaze palsy to the side of the lesion, ipsilateral abscess, and ipsilateral facial palsy and contralateral hemiplegia, which also may be present. Hyperesthesia and ipsilateral cerebellar signs may be present in the more complete form. This infarction involves the following. We have the corticospinal tract, basically the contralateral hemiplegia, hemiparesis, medial meniscus, while the contralateral loss of proprioception and vibration in the middle cerebellar peduncle. Also in the middle cerebellar peduncle, we have the ipsilateral ataxia of the facial nerve nucleus, while the ipsilateral facial weakness of the abscent nerve nucleus, which involve basically the lateral gaze paralysis and diplopia. Moving on, the third part of the brainstem, we have the medulla. The medulla is like the lowest part of the brainstem, found below the pons and above the spinal cord. Perhaps the most important action linked to the medulla is the regulation of the cardiovascular and respiratory functions. The medulla is also responsible for generating breathing movements and for regulating respiration to ensure there's enough oxygen supply in the blood. The bundles and ridges have been termed, looking at the anterior view, the bundles and ridges have been termed the medullary pyramid, and because of this, the corticospinal and corticobulbar tracts are often referred to as the pyramidal tracts. Taking a cross section, we see that the medulla it is home to the inferior olivary nuclei, which are connected to the cerebellum and involved in movement. It also contains the nucleus gracilis and nucleus cornutus, which are important nuclei of the dorsal column medial meniscus sensory pathway. There is no clear separation between the medulla and the spinal cord. Instead, the spinal cord gradually transitions into the medulla. Perhaps the most important action linked to the medulla is the regulation of cardiovascular, as we said, and respiratory function. The medulla gets information about changes in blood pressure from baroreceptors, which are found inside blood vessels. This information is sent to the nucleus of the solitary tract in the medulla, which initiates reflexive actions to return blood pressure to desired range. The medulla is also responsible for generating breathing movements and for regulating respiration. And obviously to ensure that there's enough oxygen in the blood. To accomplish this, chemoreceptors, which are found inside blood vessels, detect changes in oxygen and carbon dioxide levels in the blood. When oxygen levels fall, neurons in and around the nucleus of the solitary tract and the nucleus ambiguous respond by increasing respiration. The medulla also controls a number of other reflexive actions like swallowing, coughing, sneezing, and vomiting. A number of cranial nerve nuclei are also found in the medulla. The medulla contains a number of tracts that pass from the brainstem to the spinal cord and vice versa. The corticospinal tracts and corticobulbar tracts, which are important tracts for movement, form triangular bundles of fibers in the medulla that create ridges on the outside of the brainstem. Now we're going to talk about the medial medullary syndrome. It's also known as inferior alternating syndrome, which is it consists of hypoglossal alternating hemiplegia, lower alternating hemiplegia, or Dejoy syndrome, and it's also known as the Dejoy syndrome. It's a type of alternating hemiplegia characterized by a set of clinical features resulting from occlusion of the anterior spinal artery. This results in the infarction of the medial part of the medulla. The diagnosis, we have ipsilateral signs and symptoms such as we have flaccid paralysis, which is paralysis and atrophy of one half of the tongue. Contralateral signs and symptoms, which involves paralysis of the trunk and limbs. And we have impaired tactile, proprioceptive, and vibration sense of trunk and limbs. Talking now about the lateral medullary syndrome, it's also known as Wellenberg syndrome. It's a clinical syndrome caused by an acute ischemic infarctus of the lateral medulla lateral medulla oblongata. This is most commonly due to occlusion of the intracranial portion of the vertebral artery, followed by the posterior inferior cerebellar artery and its branches. The syndrome is characterized by one, we can have the vestibulocerebellar symptoms, which include vertigo, falling towards the side of the lesion, diplopia, and multidirectional nystagmus. So we can also have the autonomic dysfunction, which consists of an ipsilateral Horner syndrome, and we also have hiccups. Third, we can have sensory symptoms. Is initially an abnormal stabbing pain over the ipsilateral face, then loss of pain and temperature sensation over the contralateral side of the body. Fourth, we can have ipsilateral bulbar muscle weakness, which is hoarseness, dysphonia, dysphagia, and dysarthria. We can also have decreased gag reflex caused by the nucleus ambiguous. Talking about the vascularization of the brainstem, the blood supply of the brainstem and cerebellum is derived entirely from the branches of the vertebro-basilar circulation. The vertebral arteries enter the cranium via the foramen magnum and course superiorly along the ventrolateral surface of the medulla. Moving on to the venous drainage of the brainstem, the external blood is drained from the midbrain region as it empties into the great cerebral and basal veins. Inferiorly, the veins drain blood from the pons and medulla into the superior and inferior petrosal sinuses, as well as the transverse and occipital sinuses. Application of the anatomy of the brainstem in surgical practice. Basically, brainstem surgery remains a challenge for the neurosurgeons, despite recent improvements in neuroimaging, microsurgical techniques, and even electrophysiological monitoring. A detailed knowledge of the microsurgical anatomy of the brainstem surface and its internal architecture is mandatory to plan appropriate approaches to the brainstem to choose the safest point of entry and to avoid potential surgical complications. An extensive review of the literature was performed regarding the brainstem surgical approaches, and their correlations with the personal anatomy were studied and illustrated through dissection of human brainstems properly fixed with 10% formalin. The specimens were dissected using the fiber dissection technique under 6 to 40 magnification. 3D stereoscopic photographs were obtained for better illustration for this study. The brainstem forms the central axis of the brain and comprises of the midbrain, the pons, and medulla. It occupies the anterior portion of the cranial posterior fossa. It is also composed of neurons aggregated into nuclei and nerve fibers grouped into bundles called tracts, fasciculi, or lemnisci. These elements of the internal structure will be related to prominences or depressions on the surface, which must be identified by the surgeon. The brainstem is basically composed of 4 types of structures. We have the ascending and descending pathways that connect the spinal cord with the prosencephalon. We have reflex centers associated with control of breathing, cardiovascular system, and also consciousness along the reticular formation. Or third, we have most of the nuclei of the presence of most of the nuclei of the cranial nerves from 3 to 12. And we also have the cerebellar peduncles. I think that concludes my presentation, and here are my references, and I would like to thank you all for your keen and kind attention.
Wow, this was amazing, really amazing. Okay, let me just allow Dr. Kabulo to come in. Okay, so this was amazing. Congratulations, Lisa, on this brilliant presentation. Firstly, before I open to everyone to ask questions, if you have, let me welcome Dr. Kabulo. Dr. Kabulo, you're very much welcome. We're happy to have you.
Thank you so much. Thank you so much.
Yes. So we just had the presentation by Lisa on cerebellum and brainstem.
I joined late. I came late. I was in theater.
Oh, okay. It's understandable. It's always a pleasure to have you. Okay. So I was saying we just had the presentation by Lisa on cerebellum and brainstem, and she's really done a good job. So at this point, we just have questions. We just want to have questions from panelists. You may also wish to ask Lisa a question or two in case you have any.
Thank you.
Anyone with a question or any addition on what Lisa has presented? The silence may mean two things. It's either you got everything or you got nothing. So any question from anyone? Dr. Kabulo, do you have a question for her?
I think no, since I didn't follow the presentation, I don't have a question.
Okay. Otherwise, I think she's really done a great job. It was a wonderful presentation. All right.
Yeah,
so
that's good.
Thank you so much, everyone that managed to attend. And thank you so much, Dr. Kabulo, once again for being here, sparing your time that you had. So next week, we continue with the neuroanatomy presentations. Yeah, we continue with the neuroanatomy presentations, and I hope you're going to be there. So please make sure that you make time. And then the other week, we're going to have a general club presentation. We're going to communicate as the day approaches. So
Yeah.
if there's no question.
Hello, Darwin.
Hello.
Hello, yeah, Darwin.
Yes, please go ahead.
Yes. Yeah, just to add, wonderful presentation. There was a lot of things, a lot of knowledge and information passed, and then you did a good job. Yes, so just one thing to add, right? For disorders that affect the brainstem, especially disorders arising from a vascular cause, something medical students should go and learn is the rules of 4. So it is a simplified way of localizing where exactly in the brainstem you have a lesion, right? So so you see patients who present with probably damage to this cranial nerve, having motor symptoms, having issues with the spinothalamic tract, and so you put all those things together and it's kind of like tell you, okay, so you are dealing with either a lesion in the lateral pons or a lesion in the medial pons. So it's a very, very good rule. So there are 4 rules basically, and so I think you just go Google it. A paper was released in 2005 on it, and then it helps to tell you what part of the brainstem your lesion is, and then what vessel is causing. So, and what vessel is most likely to be involved in that lesion. Yeah. Otherwise, it was a wonderful presentation. Thank you, Lisa.
Thank you, Doctor.
Oh, thank you so much for that.
Maybe I can say something after that.
Sure. You can.
Okay, I didn't follow the presentation. I just want to ask, how can you differentiate clinically a lesion which is in the cerebellar hemisphere and a lesion which is in the 4th ventricle? Clinically, I think you presented on a clinical aspect of. You did also clinical correlations in your presentation.
Doctor, please can you retake your questions?
Yes, I mean when the lesion is in the cerebellar hemisphere, okay, how does it present, and the lesion which is in the 4th ventricle, in terms of headache and vomiting? Did you come across that?
Yeah, I can what I can say is the lesions originating from the ventricle would include obviously a pin. epidymoma and subepidymoma. And
Yes.
we also have like elevated elevated blood volume, and unlike other glial tumors. Also, I think well, that was all I was able to come across, but I think that's one of the major differences that we can have concerning the difference in the cerebellar lesion and fourth ventricular lesion.
Okay, there is what is called Robin's rule. The Robin's rule says when the lesion is in the cerebellar hemisphere, the patient will present with headache first, then vomiting will follow. But if the lesion is in the fourth ventricle, the vomiting will start, and the headache will come later. Because when the lesion is in the fourth ventricle, it is irritating the area postrema. It is also irritating the nucleus of the vagus nerve. So you start the patient, especially in children, that is medulloblastoma and ependymoma. The patient will come with the mother will tell you that the patient was vomiting, then the headache came later. But when it's in the cerebellar hemisphere, the headache will start, then vomiting will follow. Clinically already, when you're taking your ECG, you can differentiate those two. Thank you. At least I can say something. Yeah.
Thank you so much, Dr. Kampula. I always know that you have something for us.
Yes.
Thank you so much.
You're welcome.
Okay. Anything else from anyone? Any more additions or questions? All right. If there isn't any, I think we're going to end here. Thank you so much, everyone, for being here. Thank you to the presenter. It was a wonderful presentation, and I hope to have you again. Right. Have a wonderful evening, everyone.
Thank you.
Thank you so much.
Thank you, President.